Okay, this is going to be a toughie. 5-year-old boy, pediatric clinic, recurrent infection, serratia, and medical history is otherwise unremarkable. Family history, maternal uncle who died for recurrent infections in childhood. His temperature is slightly elevated. Slightly. He's definitely got a fever. He has multiple areas of healed scars in his arms and legs, and there is palpable cervical lymphadenopathy, but no hepatosplenomegaly. And here are the signs. Okay. And in the labs. Neutrophil function test using DHR shows markedly decreased production of ROS. That's a good giveaway there. Didn't have to give you that, but they did. And so what we're going to do is find out which of the following best describes the immunological defect in the patient. So we'll see if you have a little bit of a diagnosis here. I'm going to paste some answers and we'll zoom on down. Okay, so A, defective opsonization and complement activation. Okay, so this would be in C3 deficiency because that's like opsonization. That's where it happens. And that would cause recurrent bacterial infections for encapsulated bacteria like streptococcus, pneumonia, Haemophilus influenzae. And this patient has the serratia. And you can also see this with like, I believe with Staph aureus. And you could also have like Pseudomonas, Aspergillus, Candida. And so those are all going to have one thing in common. And that's that they're catalase positive. And so the positive DHR test, which tells us that we're not able to, it even tells us what it says, produce these reactive oxygenation species, tells us that catalase positive diseases are going to thrive here, right? And so this diagnosis is going to be CGD, chronic granulomatous disease, because recurrent fungal infections, right? Serratia, Staph aureus, positive family history of infections of a maternal relative, X-linked recessive inheritance. It's on the mom's side. Is definitely going to lead us to CGD. And that's caused by a defect in NADPH oxidase, and that's responsible for generating reactive oxygen species. And so the neutrophils normally engulf the bacteria into phagolysosomes, and then NADPH oxidase catalyzes the conversion of oxygen into superoxide radicals, and then it converts, and it will generate hydrogen peroxide and other ROSs. But in CGD, NADPH oxidase is defective, and so you can't kill these guys. So catalase positive organisms are just going to keep on coming. So CGD predisposes patients to infections with Staph, Pseudomonas, Aspergillus, Candida, and enteric gram-negative like serratia. Okay, so diagnosis, DHR. And or a nitro blue test, because its failure to produce a color means you don't have an oxidative burst. So not A. B, impaired neutrophil chemotaxis due to integrin dysfunction. That's seen in LAD. That would present with delayed umbilical cord separation. If you have neutrophil chemotaxis due to integrin problems, you'd have recurrent skin infections and just like super leukocytosis, and you don't have those findings here. So neutrophil chemotaxis with integrin is probably fine. It's not impaired. How about antigen presentation? That'd be in major histocompatibility complex 2 deficiency, which would cause recurrent viral and fungal bacterial infections due to defective CD4 T cell activation. And so this is going to be a neutrophil, not a T cell, because it's bacteria. E, defective toll-like receptor signaling leading to impaired cytokine production. That'd be seen in my D88 deficiency, MYD88 deficiency, and that results in impaired innate immunity and susceptible to pyogenic infections, so like pneumococcal sepsis. And so that would not be like catalase positive stuff. So the catalase positive tells you it's a chronic granulomatous disease. So treat this with prophylactic antibiotics like trimethoprim, sulfamexa, methoxazole, antifungals as well, itraconazole to prevent the infections, and interferon gamma therapy will enhance the macrophage activity as well to improve the immune function. And the hematopoietic stem cell transplants is also going to be curative for this condition, because that will cure your NADPH production. So you can actually not have your oxidase deficiency, and you can actually kill the phagocytosed bacteria. And yeah, catalase positive, DHR positive, DHR test, and that should all cue you into chronic glomerulonephritis disease. So hopefully that was helpful, and if it was, you know what to do.